Hello to everybody. My name is Markéta Huskova. I am the Executive Director of ANA California, and I am very proud of today's event. And I will more than happily give it over to Dr. Dan Weberg and our own ANAC Policy Fellow, Carolyn Duenas. Welcome, everybody, and thank you for coming.
Hey everyone, my name is Dan Weberg. I am the head of clinical innovation at a startup called Trusted Health, which does a lot of workforce technology and nursing staffing, which is a hot topic. But I'm here today as sort of the MC, bringing together some experts to really talk about something that I'm passionate about and ANA California has been really supporting, which is how do we address the mental health crisis in our nursing workforce? And we have an amazing panel today to talk about perspectives from inside health systems, inside specific hospitals, from an academic and global perspective, and from the innovation perspective. So I'm going to do a quick intro of the panel. If you just pull up their LinkedIn, many of you already know who these people are, so I'm going to be very quick with this because I'd rather get to the meat of this than read CVs. So, and these are all my friends, and I'm so excited to have them together, and it's great to see them virtually. So first we have Dr. Jim D'Alfonso, who's the Executive Director for the Scholars Academy at Kaiser Permanente, and also a caring science fellow and expert. And so Jim, I'm excited to have you. Welcome. We have Dr. Melnyk, who is the Dean of the Ohio State University College of Nursing and the Vice President for Wellness there as well, and a national researcher on nursing mental health. She just published a study that we collaborated on around nurses' mental health, which is exciting, and we'll dig into that a little bit as well. We have Dr. Bonnie Clipper, who is the Chief Clinical Officer for Wamby and an innovator and co-conspirator with me in many respects. And Dr. Anita Gerard, who is the Vice President for Patient Care Services at Cedars-Sinai, as well as the ANA California President. So we have a great perspective today, and I'm excited to have our colleague Carolyn over here, who will introduce herself, run the show and moderate the questions, and let's dig in and figure out how we can help our workforce. So Carolyn, take it away.
You're muted, Carolyn.
Oh, sorry. Hello. Good morning, everyone. Welcome to today's discussion. My name is Carolyn Duenas, and I'm delighted to join such a stellar panel. I am an executive healthcare professional with over 20 years of nursing experience, and I was confirmed into the American Nurses Association of California's 2022 Advocacy Institute Fellowship Program, and my focus is on mental health solutions for nurses. So I'm excited to be here, and I'm ready to get started and get right into the questions. So thank you all for joining us today. Thank you for all the panelists and everyone that is included into this program today. So let's get right into it. One of the first questions I have is for Bernadette Melnyk. What would you say are the biggest barriers at the federal and national level to nurses accessing mental health services and solutions, Bern?
Thanks, Carolyn. First, I just want to emphasize this issue of burnout, mental health problems in nurses and other clinicians was an epidemic prior to the COVID-19 pandemic. Now we have a mental health pandemic inside of the COVID-19 pandemic. I didn't join you today to depress everybody because we have a lot of opportunity in front of us, but there are multiple barriers that do exist. For one, healthcare systems, the C-suites of America have got to recognize this problem, and they have to invest in it. Wellness is not a nicety. It is an absolute necessity that will have huge return on investments, value of investments for our healthcare systems all across the country. I want to share, if you have not heard of the Laura Breen bill that has just passed the U.S. Senate. It's the Dr. Laura Breen Healthcare Provider Protection Act. At the federal level, we have not had funding for this issue. That's been a huge barrier, even at the National Institutes of Health, to fund a study on nurse or clinician well-being has hardly happened in past years. However, through the National Academy of Medicine's Action Collaborative on Clinician Well-Being and Resilience, which I'm blessed to be one of 60 leaders in the country serving on that collaborative, generating evidence-based solutions. We have really brought major national, federal attention to this issue. The second thing I want to talk about as a barrier, there are still multiple states for licensure that ask questions about mental health that are not currently pertinent. And as a result of that, nurses do not like to disclose that they've had a mental health issue. They are concerned labeling licensure. So these are only two. I could talk for an hour about barriers, but I'm going to turn it over to our next speaker. But again, there are many that we have got to overcome, but I'm optimistic we can do it because the COVID-19 pandemic is shedding a lot of light on this issue, which is going to help us moving forward.
Yes, absolutely. So funding is a huge issue, and that the stigmatism also connected to the mental health. Yes, and that definitely will trickle down to the different health levels and operational levels. So let's continue on that same path as far as the barriers are involved. Jim, what would you say are the barriers at that health system level?
Hi, everybody. I'd like to bounce off Bern's comment around well-being and resilience. And as much as that applies to an individual, it is directly and interconnected with the organization that they are employed by. So the well-being and the resilience of the organization can be a potential barrier during times of crisis. And these crises are global. It's a crisis of human caring. It's epic proportions. And although I think we all would admit our systems are broken in many ways, there are inefficiencies, problems with communication, fragmented care. We could go through all of the different challenges that healthcare systems have. When you superimpose a pandemic on top of these ineffective or broken systems, you really start to see the lack of resilience, flexibility, and adaptability of the organization. So the greatest barriers to mental health of those who are employed in organizations is what I could identify as trust. Trust that the employees know that the organization is on top of things. It's going to communicate effectively, frequently, and relevant information to them, is going to have their best interests in mind and make sure that they're safe, and provide the supports that are required. One article I'm sure many of you have read or heard more about is the 5 requests that healthcare workers have. And those 5 requests are: hear me, protect me, prepare me, support me, and care for me. And for organizations, it really is incumbent upon their culture and on the functional systems across the throughout care, care delivery systems, that they function efficiently and that they look at the bigger picture and are taking care of those who are important to their mission and their vision. So the barriers, I would say, are multiple. And of course, there are external barriers, internal barriers, but organizations, like Bern said, need to make firm commitments to build resiliency as an organization, to develop the cultures that can deliver on the promise, not just to those who are coming to them for care, but for those who work and are employed, and to make sure that those cultures are filled with joy and meaning. And that people can stay well and take care of themselves, which is something that is sometimes counter to our society, where it's work more with less and under these stressful conditions. How do we make sure that our employees can be well cared for and take care of themselves and their families? So I think Anita will build on that concept to the operational level, but from an organization's perspective, it's not just delivering on the external mission, but to deliver on the internal mission to those that are employed.
Okay, very well said. All right, so Anita, at that operational level, would you say there are different barriers to nurses or some along the same lines as what we've been discussing?
I think it's really difficult at the organizational level. There's lots of things provided, but nurses don't want to even go to their doctor. So the stigma, as Bern was saying, around mental illness or even the ask for help is huge. One of the things that I did at one of the organizations was the governance councils made a resiliency toolkit. So they built out what can you do with the incident that happened to you? What can you do 2 days from now? And what will you do 2 weeks from now to try to build a resilient culture? All they did is compile from an organizational level all the different things available. They made toolkits. They left them in paper sometimes works. It's a 2,000-year-old technology. And they left them in the break rooms, and we actually saw a bump in usage of the different things that you provide at the organizational level. So I think that's really important. I also think grounding as leaders and just each other. One of the major ways that we survived through COVID was laying eyes on. We said every day, do you have eyes on? And at Huddle, being able to say, there's some teams that use the 10-point system. Just go around the Huddle room. Where are you at today? Somebody who's always a 10 or always a 9 is now a 6. That's a problem. The team jumps in to help that person through the day at least. Those are just some micro practices. I think we also did a series of letting go ceremonies here at Cedars. We realized that the trauma that our people had been through with COVID when we reached 500 patients in a 1,000-bed hospital was pretty significant. So in March, we did a variety of letting go ceremonies on the plaza level with the chaplain services, with invisible ink, so that you could put your issue, your problem, your person who passed from COVID, your caregiver, your care colleague that you're worried about, into the bowl and kind of release that from yourself. Again, a variety of micro practices. Caritas, I'm a Caritas coach with Dr. Jean Watson as well as Jim, and using some of those Caritas processes. We had the talking stick. We did a circle group. We brought together people in a candlelit room with spiritual care and had them go around the room if they were ready and willing and wanting to talk about the issues that had come for them during COVID. And I was shocked and surprised to see that most of the issues, there were people in the room who had lost significant people of their family that they've never even told their colleagues about because there was so much grief and, that they just wanted to show up for work and kind of pretend that didn't even happen. So I think it's really important to us to open the door for people and to allow that vulnerability and to allow them to have a safe place to be able to talk about things. And then again, as Bern was saying and Jim, to have organizational resources that are available to them, and then we promote them as leaders so that they know that that's available for them. I also looked today at the ANA website. I was just curious to see what's going on because they're always doing something new. And there's some wonderful videos on cumulative grief, which I think that is a great, to me, that resonated, that through this COVID epidemic, we have really seen cumulative grief where people have not been able to handle it in the moment. So they come to the point where they're just, I'm leaving the profession. I don't want to take this anymore. So on the website, there's lots of valuable tools and resources there. And then we also did a bereavement rituals of just listing in rooms with white paper, how many rituals that we've given up, changed, or have we don't do anymore because of COVID. So I think giving voice to it is a really powerful tool for all of us in nursing.
Giving voice. And that's, I think, one thing that we really lack, that we don't like to discuss some of these things. We'd rather just continue, let's keep through it. Everyone's going through it. But that's something that I've definitely noticed so much, that people just don't want to discuss things. They want to just continue pretending to be happy and just put it away. But we definitely need to have a voice and let them have those voices. So thank you so much, Anita, for that.
Hey, Carolyn, can I jump in just to hit a point there too? I think all three so far have talked about the impact of leadership. And, in nursing specifically, we put so much emphasis on these things like HAPUs and CODIs and central line infections and all those things. And we don't put as much emphasis on the impact that leaders have on outcomes for our patient. And there is research, and we may dig into this later. There's research that links poor leadership to not only burnout, but poor patient outcomes. And so I think as a profession, we need to do a better job of also holding our leaders accountable and not just saying that's how Jim or Susie or Anita are, but holding them accountable to the standards of what evidence-based leadership is too, because that will help create the culture that we were talking about here today.
I want to add to that, Dan, if I may, Carolyn.
Yes,
There's so many facets to this, and I think the leadership one is obviously what each of us are reinforcing. Valuing what some people term as soft skills, which we all know are the hard skills. Really being able to care for teams in a way that makes them want to stay. And one of the greatest barriers healthcare systems have right now is people leaving the workforce. And they're overwhelmed, exhausted, and fleeing. We know, certainly history tells us that they leave on great part due to the relationship or lack of relationship they have with their own leader. If the culture is not promoting a higher or more evolved leader with emotional intelligence, social intelligence, and relationship skills, then the risk is obviously turnover. But it is tenfold right now, and seeing incredible churn in the organization, turnover of people leaving, not just the hospital, but leaving healthcare, choosing early retirement. I had anticipated people might become exhausted and opt to retire because they were eligible, but maybe they didn't want to before. But now we're seeing increased numbers of retirements that are quite alarming, because it's a huge brain drain on the organization. A lot of the talent and knowledge that leaves with those retirees is very difficult to replace. So the real challenge of barrier is around continuity, safety, and making sure that our systems remain solid and functioning to their highest ability.
I agree with that. All right, well, thank you so much for enlightening us with the barriers that we have so far. Let's continue with Bonnie, and I'd like to know what you think are the barriers in implementing technical solutions within the healthcare institutions.
Yeah, absolutely. Thanks for the question, Carolyn. First, let me say it's a pleasure to be here talking about well-being and focusing on solutions, because I think so often we hear about the issues, but it's really a delight talking about how we're going to actually impact this in a positive way. So from a technology perspective, nurses really want solutions that fit into their workflows and don't add yet one more thing to do. So we actually focused on how is it we can help nurses do the things that they're really good at. And one of the ways that we've come back over and over to doing what we do at Wamby is basically helping nurses build a really positive culture. So often we kind of make fun of that and poo-poo that, but essentially when you think about Maslow world, this really is one of those building blocks that we have to have in place. We have to feel safe and secure in where we are and what we're doing, who we're working with, who we're caring for. So we've actually used a design thinking model, whereas we've spoken to many, many nurses, managers, CNOs, leaders, and patients to get a sense of what are the real issues? How is it we help you create a positive culture so that we can build upon that? Because we all know the feeling you get working in a culture that you want to be part of is completely different than the feeling you get when you've had maybe some of those less than positive experiences, or maybe even some of those toxic workplace experiences. Those aren't fun. So we really focus on using gratitude as a building block and then building upon that. What we've seen as a result is that through technology, the adoption in our platform is easy because it's very intuitive. And it also is engaging because it's gamified. So generally it brings people back to it over and over. Certainly we have a variety of users. Not everyone is a nurse, not everyone is a physician. We have patients that use this as well. And we have business office, food service employees. What we've learned is that the easier the platform is to use, and the more we can solicit feedback from patients and their families that go to the end users, it's an incredibly powerful experience for them to have, because over 95, 97% of the feedback from patients is very positive. And there's nothing that makes your day better than when you see a comment from a patient about what a difference you made in their stay or their outcome. That's hugely impactful. So we really try to simplify the utilization and the tech adoption piece by making it easy, streamlining it into workflows, and then building it in such a way that it gives patients a voice so they can share their insight and their comments with staff.
So you've been working with Wamby for a while now. Could you tell us a little bit about what you had to do? Like, how were you able to get Wamby implemented in these institutions? Because there are many possible solutions out there, but it's very hard to actually get into these institutions. So could you talk a little bit about what was your struggle, or how did you get Wamby implemented into these institutions?
Sure, I'll give you a little more detail on that. So because we've actually received a lot of input in the design, so we actually have an executive advisory council that gives us input. We have a patient and family advisory council that gives us input, and then we have a nursing innovation council. So we get a whole lot of feedback. And then we actually use that to kind of guide our design, our build, our graphics, our interfaces, so that it's very intuitive and easy. When something is an easy solution, then it's not a matter of a manager continually pushing on people to use it, because it's there at their fingertips, it's on your phone, it's super easy to use. You know, there are differences too in adoption rates, and some of that is demographic based, right? We see that nurses that tend to skew towards the boomer or older Xer maybe don't adopt as quickly as those that are millennials or Zers. So certainly there are some of those tech adoption nuances that we see along the innovation adoption curve. I don't think we're different than any other solutions that are out there, but really because we've listened to those voices up front, and it takes time. Sometimes it actually slows things down so that you can go faster later. And that's allowed us then to help the organizations with the technology uptake so that they actually use the platform that will drive their culture and make their experience in their workplace a better one. And it will also help them get that feedback from patients. That's the real secret sauce for us. Getting that feedback is incredibly important because it's such a driver, particularly for nurses that are in the trenches giving the care.
And you've seen, how has the feedback been with Wamby's use so far? What have the nurses, like, because I know we're getting a lot of the feedback from the patients to the nurses, but what are the nurses saying? How do they feel having that gratitude at their fingertips now?
Usually what happens the first time a nurse actually signs in to see the comments from the patients, it is not uncommon that they cry. Because their patients say amazingly positive things. Their patients will say things like, you know, I'm very grateful for Margaret. I know she was really busy today, and just the fact that she brought me a late lunch because I came back from surgery, later than expected. That was really thoughtful. And in Nurseland, we just do these things. We're on autopilot, so we just do what it takes to care for the patient. We do all the workarounds in the world, and we just provide care. But patients notice this, and families see it. And when you can reflect that back, it's like a mirror to a nurse. So they do feel seen, and they do feel heard, and that goes a really long way.
And I remember when I just saw Wamby and this gratitude solution, it took me back when I was doing my bedside nursing. I remember seeing the little cards at the bedside table, if you want to thank your nurse. So it's like by the time the patient fills it out, they'll send it in, you'll get it maybe 2 weeks or a month afterwards. And by that time, you don't even remember who that patient was. So this is like more real time. I'm being appreciated within that 24 hours sometimes. So it's a very good feeling to have that gratitude. And I can see the difference, I think, even in nurses, just having that thank you. So that's definitely something that's a very innovative solution. So I'm very happy that we're finally catching up with 2021 technology. So that's wonderful. So talking about innovative solutions, this question could be either for you, Bonnie, or Bernadette also. What are the most exciting and innovative approaches that you have seen recently, and what makes them really stand out from the rest?
I'll go ahead. And Bonnie, I'm so excited about your innovation. I've been promoting a dose of vitamin G for gratitude every morning and night. I think one of the simplest evidence-based practices to reduce stress and improve mood is daily practice of giving and taking a dose of vitamin G. So thank you for what you're doing with your innovation. I'm sure it's making a big difference. Carolyn, I want to stress, we know the root causes of burnout. We must do two things in our healthcare systems. We've got to fix system issues first that we know are causing burnout, understaffing, 12-hour shifts. Our research that I did in collaboration with Dan, my prior studies have showed the longer the shift work, the poorer the mental and physical health outcomes of nurses, and the more preventable medical errors that they make. I am banging this drum all throughout the country right now to the C-suite. The number one feedback I get on this burn, how can we stop 12-hour shifts? Our nurses love them. You know, they work 3, off 4, but the days after they work, they're burnt out, or they go and work some more at another facility. If our children wanted to jump off a bridge, would we let them do that? No, we've got to use the evidence we have and translate it and stop that practice. It's not good for quality and safety of care, and it's not good for our nurses' health. So focus on system issues. Bonnie, culture. I always say culture eats strategy for breakfast, lunch, and dinner, because it does. We developed a valid and reliable culture scale here at Ohio State. And our studies show culture impacts what people believe, how they feel, and what people do. But culture change takes time. So besides the culture, the fixing the system issues, we've got to offer evidence-based programs that we know work. We've developed a 7-session cognitive behavior therapy based program. It's actually off of my 28 years of research career with my CBT-based program for children, teens, and young adults. We tested it in a randomized controlled trial with nurses. We show beautiful outcomes. We can't wait 17 years to keep translating what we know works from research in the practice. So this Mind, Body, Strong program, but also other evidence-based programs we know work, we got to implement them now, not 15, 17 years from now.
Yeah, and I think, you know, Bern, I completely support those from a conceptual framework perspective. And part of it for me is that while we have to innovate, that means we have to be willing to get messy and dirty and disruptive and butt heads with the things that need to change. So we need to really take a look at, there are nurses who would stick around if they could get benefits working 2 days a week. Right? Well, our labor laws, our processes through human resources don't permit that. Blow them up. Why did those get to dictate the rules? If nurses want to work 2 days a week and need benefits, why aren't we creating things like that? Why aren't we looking more aggressively at how we can innovate our shift length, whether it's 6, 8, or 10 hours? Well, we say that kind of mucks up the schedule, and then you have this little dangling thing over here. Get over it. We have to figure out how to fix those things. One of the things that I see has happened in nursing that, in my opinion, has made this a crisis is that we have completely taken the joy out of caring for another human being at their most vulnerable point in life. That's why most of us went into this, right? It's a combination of empathy and compassion in that place that we thrive, in that place that we shine. That doesn't mean you can take care of 6, 7, 8, 9, 10 patients. Those old productivity standards, those were driven by management engineers. That's like making mufflers and tires and producing Kleenex, right? Those aren't standards that humans should apply to caring to other humans. So that is absolutely something that needs to be disrupted and transformed at this period of time. In order for us to bring joy back, we have to build these cultures that are essentially built from the ground up based on gratitude, based on the importance of working with a team that you want to be with, that's got your back and is going to help you. If it means settling your post-op patient because you're at lunch, we need to know that our team will do that. So those are the things that I feel like there's a tremendous amount of opportunity right now for us as nurses to go after this. This is our profession. So we need to go back to building joy, building cultures, and figuring out how to fix these issues.
And what would you say, Bonnie, are some of those tools that you have seen out there that has been able to facilitate some of these workloads on these nurses? Because I know you really, I remember watching one of your, you were doing an interview and we were talking about how there's a lack of technology really being utilized as best as we can in the healthcare industry because of that lack of that nurse knowledge to the ones that are actually building these technologies, right? So we definitely need more nurses into that space. But is there anything that you've seen that people have been working on in that space that has been innovative for that workload for these nurses?
You know, I think we're going to have to be much more open-minded around technology-enabled staffing. You know, certainly for me, that means building a good culture, right? That's kind of a framework that's kind of a keystone that has to be there. And in Wamby world, we fill an amazing space there, right? And there are also other technologies that we need to help us leverage ourselves and act as force multipliers. There's a lot of work being done around robotics. There's a lot of work being done to incorporate AI into our nursing practice. We also could utilize remote patient monitoring inpatient to help lay another set of eyes and ears on our patients to actually help make our loads easier. So there's really two different ways you can do this, right? One of them is that we can build upon the existing levels and say, jeepers, maybe a nurse shouldn't be caring for 8 or 6 or whatever patients, or we can go completely the other way and say, if we allow registered nurses to operate at the top of their license, there's a way for us to build a tech-enabled team model here, right? We got to quit fighting over who gets to start the IV and who gets to draw the blood, and instead go back to using unlicensed personnel that we delegate to and supervise, find those individuals, which even though we compete with Amazon in that space, I bet they're easier to find than nurses. And then figure out how we can build team-based models, use technology to leverage as a force multiplier, and then build a rock star culture that people want to be part of. That for me is always going to be the key. No matter how much money you throw at things, if people don't want to be there, you're not going to fill the vacancies.
I agree with you, Bonnie. I think that we need to take a whole different approach and develop an entirely different care model and utilize technology and e-presence and all the different things. Let somebody on the television do the admission and update you on what those critical pieces are. There's companies out there working on it, but we're so kind of stuck in our old ways that we just need to take a whole different approach and just blow it up and really practice at the top of our license, and also utilize those clinicians. Even what about if pharmacy gave medication? How much time is spent every day of nurses giving medications? So I think that's what's going to be needed as well for our retention and our well-being and our resiliency, to incorporate technological solutions. So thanks for bringing that up.
Yeah, no, and I couldn't agree more. I think that we have to get out of our own way. We have to stop thinking the way we've always thought. Our leaders have to change or get out of the way. And I think we're going to need to figure out, how do we move forward as a profession? Otherwise, this inflection point we're in isn't going to end so well for us. So we have to figure out how to change our culture, bring the joy back, and really leverage the skills that we have.
That's awesome. And Carolyn, I want to jump in because I have some thoughts. You've got my brain spinning, all of you. And so, Bern mentioned a lot of interventions that have worked that are evidence-based. Bonnie's talked about technology and gratitude and ways to kind of enable the workforce. I'm curious with Anita and Jim, how do you create, as leaders in the operational space, how do you create space for this stuff to happen in the workday? Because one of the barriers that I've seen and that we've talked about is that, there's all these great apps and all this great stuff out there, but nurses are left to deal with it either before or after their shift, and that's where it drops off the cliff. So how do you operationalize some of this to make mental wellness and mental health interventions part of the workday and the culture as they step through the door?
Well, I'd let Anita go first, but I'll build off of what Anita offered. And I think it's these caring cultures. And, so we keep using the term culture, and Bern said it takes quite some time for a cultural. And in our organization, we spent 12 years integrating caring science, the theory of human caring, which gives you a set of values, an ethic, a philosophy of how we care for self and care for others. And I would say we're not perfect at any of that. We're just perfectly committed to it. And I think that in being perfectly committed, you see all kinds of innovation and creative things happening all around. So it ranges from having on-unit caring places and spaces for staff to go to step out of the fray and to be able to go someplace to center and to relax and maybe put headset on and maybe practice some micro practices of resilience, which we'll talk about later, and have that opportunity to pause. I think it's also at all levels, not just for the frontline nurses and the abilities like from huddles, using sports analogies, but building a common language around cuddles and caring for each other. It's been a lifelong thing of mine. Let's bump the sports out of nursing and put more of the humanity into it. But, you know, do you start with notes of gratitude? When we first started doing morning huddles and cuddles, people were very uncomfortable with delivering a caring moment. But the minute you got them started, you know, 12 years later, people tell the most compelling and beautiful stories of things that are important. It's sharing their story. It's sharing gratitude. Sometimes it's sharing their concerns and their struggles too, so that others can support them. But I would say the most important one from my perspective, and I think you know that, Dan, as well as others, is helping our leadership evolve beyond this, you know, industrialized militaristic model of what leadership is, top-down strategy, do as I say, you know, and this moving from competency, which is military-based, to, you know, more of a literacy, where people actually challenge their thinking, are open to new ways of being, unlearn things that are no longer effective, but someone told them that's the way you lead teams to success. But at the same time, you've just spirited them along the way. So leaders are your on-the-unit source of holding space for the culture. And if the leader is not present, accessible, is not showing up in a way that reflects the values of the culture you're trying to build, and ultimately it becomes destructive force, toxic, and teams start to lose their cohesion, and before you know it, you have people leaving. So, you know, it's all interconnected. It is moving all in different, you know, at the same time, in different places at the same time, and at all levels, but it's a journey. I don't think there's any quick checklist to help move our cultures to another time and space. It's just persistence, it's a commitment, and it's really understanding that it takes time, patience, and a lot of love to help get teams to another level.
Yeah, thanks. To build on that, I loved how you said holding space, because that's so important. We had a big caring fair for our healthcare workers, and it was a super busy night. We had 1,000 patients and nobody could get away, but we had nurses that would go up and even try to relieve other nurses, and they went, you know, nurses, it's too hard sometimes. But they did send back the message that they loved it, that we were holding space for them, even if they couldn't come to the caring fair. So I thought that was so cool, and really helped me understand that that's what it's about, right? As leaders and thought leaders, and the people on the call today, is for us to hold space around this issue and create, you know, a culture where it's expected, and we all find our own resiliency, our home. I saw somebody talking about home resiliency and what we do at home, and using comedy as well. Some other things that we did for micro practices is in our PACUs, they actually have a singing bowl, and they start their shift in the PACU with a singing bowl to kind of center the work that they're going to create, and that sacred, amazing work that they do. Our IR staff had taken HeartMath, and they actually had a patient who his blood pressure, he was in the cath lab, his blood pressure went all out of control. And he said, whoa, wait a minute. I know this thing called HeartMath. Let me get under control again. And the two nurses said, we know HeartMath, we'll help you. So they all got in coherence together, and we're able to not use medication, and we're able to get his heart rate and blood pressure down. So just super cool. Again, micro practices. And Bern, I love that you're working at the bigger national level to help us take on those big national pieces. Also creating meditation rooms. People actually use it if you create the culture to use it, and you send people on break and say, just take a minute and have a chair. Let the staff create their own meditation rooms, though. They need to create it. It's their space. They need to own it. It needs to be for everybody on the unit or clinic or wherever you are in ambulatory areas, but let them build it themselves. Just help, as leaders, help provide the funding to be able to do that, or find donations. There's lots of donations for meditation and Zen rooms. And then I also think we need to work on workplace violence, because with coming out of COVID, that workplace violence is truly brutal. And I've never seen anything like it in my 30+ career. So I think we have to address the workplace violence issues that we're dealing with in this country.
I am so glad you talked about the meditation room. And it's not just the meditation room being there, but you definitely need that culture that promotes you actually using the room. because I remember having, you know, those stressful days and the room was there, but I would have to tell myself, I need it for myself. If not, I'm going to have a nervous breakdown. So I'd go, I'm like, listen, just watch my patients, just give me 15 minutes and let me go. So I would go to myself, but it wasn't something that the managers would say, you know, go, you know. So it's very important to definitely have that leadership that's going to say, hey, you know, set yourself some time to go take care of yourself. And in a way, having that permission, right? Because sometimes, oh no, we're so busy, we can't, you know, stop what we're doing. Our patients need us, but they need us, but we need to be whole too. So thank you for bringing that point. And also thank you for talking about HeartMath, because it goes right into my next question that I have for you and for Jim, because you guys have actually had HeartMath and Wamby implemented into your institutions. And I wanted to learn about how were these solutions implemented into your institutions first? And also, what has the response been? I know you shared a little bit about the patient and the nurses being able to do, but overall, what has the response been for the use of HeartMath and Wamby at your institutions?
So for HeartMath, it's been, you know, I think as leaders, we need to first kind of strategically identify people who will be your early adopters and promoters of it, right? So instead of just putting a big blast out there of who wants to be, really trying to strategically build a program so you create some structure in your organization and pick some key leaders and clinicians at the point of care who are just champions around that, the topic of HeartMath or any program you bring in, Caritas coaching, anything like that. And then it takes a voice of its own because if you get the early adopters who really believe in the things and utilize the platforms, again, whatever platform it is, they'll promote it. And that's what you want, right? You want them owning it, not a leader saying, do this, but them saying, I want to do this. This is so cool. So again, I think it really rests with promoting it and then letting them have the journey of it. And with that, you know, we built to about 35 HeartMath Caritas coaches when I was at Stanford, and that was enough to kind of overwhelm the system into a more compassionate culture that people knew, again, micro practices, actual things they could do that to help soothe themselves and their patient and care for themselves first. I think that's the big issue, right?
Yes.
Is allowing permission to care for themselves first.
And I'll add on to that, Anita. Our experience has been 12 years now, actually a little bit longer with the first introductions of HeartMath. And I would say it's at all levels. We've got a systematic approach where we actually have caring science leaders at the region, but we also have leaders at each of our 21 facilities. So we have in all, I think 87 HeartMath trainers for those 21 facilities. And more than that in Caritas coaches, which are special coaches in these micro practices of caring science, whether they be Caritas rooms or, you know, all ways of knowing and ways of practicing with patients without requiring a prescription. So helping build autonomy of practice, helping them experiment with ways to be, I would say, more present with each other, but more importantly, more present with their patients and families and teams. So as a culture, not just doing education, but actually practicing it. And I think during COVID, what we saw was an incredible expansion of these programs, a demand for them. People were reaching out to us to say, can you come and do a HeartMath program for our team? We think they need a refresher, a renewal, you know, something, a reminder of how to, you know, build resilience and decompress. We also offer caring circles through our Caritas coaches, special teams. We've had, unfortunately, nurses who succumbed to COVID, very traumatic, devastating experience, and mental health wise, you can just imagine the toll on the entire hospital to lose a beloved colleague. And we instituted caring circles, which then took off like a wildfire and were able to be conducted virtually as much as in person. So we've learned a lot through COVID. Some things we have taken away, asynchronous capability of recording things, sharing memes, videos, educational sessions. Even our friends from the Ohio State did resiliency training and reinforced a lot of the wellness principles of Bern's program and we recorded it. And because we know, like Dan said, teams are busy, you just make it accessible to them whenever and wherever they want it, on demand. And the same is true of caring science programs. The same is true of memes, poems, videos, inspirational things that people find, and we share them so that they can, spread across the organization. The amazing thing for us is we have this Scholars Academy, and we have a lot of people pursuing their doctorate as well as their masters, and we have incredible number of projects and research that's been done around HeartMath in particular, and the integration of theory, caring science with HeartMath. I myself did my DMP project on how to demonstrate the ability for CNEs to flourish through HeartMath programs, and they did biofeedback as a kind of a method that they introduced into their practices, daily practices. And so we've seen incredible sharing and spreading of these best practices. Like Bern said, we don't have 17 years to get this together, but we share stories, we share results, we share programs, and they keep growing. And that's the beauty of it. And as Anita said, in the beginning it was very strategic, picking those people who were highly inspired, those people who really were passionate about the work. But now we have faculty from our community who are asking about our programs, and we've actually provided community health funds to send faculty in the community to get these same skills in HeartMath, caring science, whatever. So then it becomes integrated into the curriculum of those programs in our community. So it's mushrooming, the culture shift is there, and I think, quite frankly, I think we've done a relatively decent job as far as weathering the storm. And I really believe in great part it's due to this cultural shift. It's due to this sense of love and care. And even though it's not as pervasive as I would like to see it, I think that we can all acknowledge that teams are incredibly powerful in supporting each other's mental health and well-being. And I think these skills, whether it be HeartMath, caring circles, or other innovations that we have, all support that end goal.
Great point, Jim. And I want to ask Bern as well. So we've heard about HeartMath, we've heard about Caritas, caring science, we've heard about CBT. There's a lot of things here, a lot of interventions that people are trying. And I know you have a purview over all of that. You have a lot of research in this and the effectiveness of lots of things. So I would love to hear your perspective. Is there a magic bullet? Like, is one better than the other, or is it really just putting these resources out there and being available? What's your perspective on all of that?
A couple of big thoughts, Dan. For one, there is no magic immediate pill bullet. There just isn't. This is what I call character building journey. But at Ohio State, you've got to take a multi-component approach to tackle this. Top leaders, middle managers, and supervisors, that was mentioned. You can be resource rich like we are at Ohio State. Tons of evidence-based wellness, resiliency programs, all of that. But if you don't have engagement and you don't have the support of leaders, managers, and supervisors, people aren't going to engage. And so we also tackle this at the grassroots level and then policy, but all within a culture that supports wellness. And our latest study showed the health and wellness outcomes of nurses were better if they believed their healthcare setting supported their well-being. So again, that wellness culture support is critical. And then I want to share one last thing. I am currently in a national network of 30 chief wellness officers across the United States, but they are all physicians except me. To me, that's outlandish. Why are we letting physicians right now take the lead on wellness prevention, clinician well-being? Our nurses are so equipped to go into these leadership roles. We just need to empower them and say, take a risk, apply for that position. The other thing, a lot of these physicians are focused narrowly on physicians. And every call I get to consult, I tell people, you can't narrow this to one healthcare profession, because you got to build that culture and take this multi-component approach. Yes, we should tailor certain interventions for certain clinicians, but overall, people gotta invest in a chief wellness officer that will spearhead this across the organization, and nurses can do this well.
That was so, yes, I like that multi-component approach, because it's not just one issue, it's a multifactorial issue. And even if you do one thing, there's still other variables that will definitely affect that outcome. So that is very, very true. With the solutions that you guys have actually seen out there, Mind, Body Strong, Wamby, HeartMath, how are you guys evaluating these solutions to see how effective they really are?
Evidence-based quality improvement is critical. If we don't measure outcomes, we can't document our impact, and we can't hotspot. We use the Health Productivity Index by IBM Watson. So we meticulously measure outcomes every single year. I can tell you what units in my big medical center are struggling with depression, stress, and anxiety. And my wellness team then concentrates on those units and tailors what we do, because we've measured outcomes. You gotta measure outcomes and use that data to improve what you're doing.
Yeah, and I would say, Carolyn, at Wamby, we measure the outcomes, and we focus on things such as how do we impact burnout? And as we know, there's many different levers. So we actually teased out some of the key components of the MBI, the Maslach Burnout Inventory. So we've seen a 62% improvement in our end users feeling valued at work. So that's one of the levers. And we've seen a 71% improvement in receiving adequate recognition, which is another lever. And then we see a 98% improvement in receiving regular feedback for a job well done. So we broke down the individual levers and measured those components.
Well, and we have done all levels of measurement. So of course there's organizational measurement that looks at the bigger picture. But from evidence-based projects and evaluating outcomes to research, to now looking at system-wide research that we can do in partnership with some of our academic partners, it's something that we're constantly looking at. How do we measure the effectiveness? And of course, things like the academy, the impact of professional development, career advancement, retention, and so forth. We look at those indicators as well as how they interconnect with all these other programs, because students and members of the academy are all part of these self-care and wellness programs that are across Northern California. We do them with partners as well, and we publish our results, we share what's going on, and we're always looking for opportunities to present when we could present at conferences and so forth. So it's making sure that you're sharing what you're learning continuously so that people can see the fit for themselves, explore, and we get we've had international teams of nurses come to kind of experience our programs and to learn from our teams as well.
Yeah, I would say this, a lot of the similar things to what Jim mentioned, and Press Ganey also has 5 validated questions on the Watson Caring Science model. So when we implemented that, you can also use those 5 questions to correlate with your Press Ganey if you're a Press Ganey patient satisfaction client. But then also doing our own individual studies. And then we use another survey here at Cedars-Sinai that's Glinton, not to promote that product. It's just a survey that gives you both quantitative and qualitative answers. So we can tailor the survey to meet the needs. So as we launch the Caritas program here, we'll be surveying around that to make sure that we're achieving outcomes. Somebody in the Denisha had asked about turnover, workplace violence or injuries and absenteeism. And I've definitely seen in my career, it does decrease. The more you are intentional about resiliency and developing it through multiple projects and a multi-pronged approach in your organizations, definitely those indicators go down and improve. And it's wonderful to get to see. So thank you.
Yeah, likewise, over 12-year, history, opening new hospitals and experimenting with opening that hospital with a culture of literally from hiring to building teams and putting them together, training, onboarding, orientation, and so forth. We have a lot of experience in understanding, the impact of this on team coherence. Like Bern said, are they engaged? Do they find joy in coming to work? We literally take narratives from our nurses on, entering into the hospital each day. One nurse said, I envision a giant rainbow over the hospital, and that gives me hope for the day. And, being able to be their full person, their whole self, and to bring all of that. We have a lot of nurses who have deep spiritual beliefs and don't have any way of understanding how to express it in their practice. And through caring science, of course, the spiritual dimensions of mental health and well-being are an important part. And so they actually, through the theory and through the practices, are able to show up and bring their strong sense of spiritual connection to their work and have a way and a common language of how to build that with their patients and families. Great satisfaction in that. Versus denying it. I think that's what I would rather say. I think a lot of facilities would just bury it and say that's not a place for that. And that's part of the old systems that Bonnie was saying they need to be flushed. And the old thinking of, leave your personal stuff at home. When you're here, you're on the clock for eight hours, hopefully, if that's Bern's way, right? And not 12 hours. But, the reality is people come and they bring all of themselves with them. And we've learned so much more, even with COVID, of the family stressors about children not being able to go to school and who's going to care for the children, concerns about taking COVID back home with them when they go home from work, or constant fear, anxiety, stress, and the depression that goes along with it. I mean, it's inescapable. So, are teams conscious of this, or are they suppressing it or burying it? Well, we want them to be open and having dialogue. We want them to be present on the units. I think my greatest struggle is with the focus on metrics and the focus on reporting and the focus on the operational pieces. Are our managers even present on the floor? And are they connected to staff? And so there's a vigilance around Well, if people need to do certain things operationally, because that's the business, then who's going to be present for and caring for the unit and holding that space? And even I are talking about holding space in the care setting so that the staff have some cohesion, some drawing force that pulls them together.
And Bern, that's been a focus of one of your studies as well, the evidence-based practice adoption and the frontline manager being one of the largest barriers or supporters of the adoption of evidence-based. Can you talk a little bit about that? Because I know that's a passion of yours too. Hope you're on mute.
Yes, but I want to share a study I just came across that I think everybody's going to be shocked when you hear this. We base our 17-year time research practice time gap on a 2000 study. There was a study that came out just this January that said it's not 17 years, it's only 15 years now. And they've got great evidence, seriously, to make that statement. So at that rate, it's only going to take 150 more years for the research we generate to get translated quickly into practice. That's absurd. It's unacceptable. In the study we did, this is probably one of the most enlightening findings. We surveyed chief nurses, like 260, all throughout the country, on evidence-based practice, their own and what was occurring in their hospital. We also asked them, what's your highest priorities as a chief nurse? Number 1 and number 2, quality and safety. Not surprising, but evidence-based practice was at the bottom of their priority list. We had a great aha moment. We said, chief nurses want quality and safety, but they don't recognize the secret sauce to getting there. Evidence-based practice plus clinician well-being. So when I do all my talks now, I emphasize you got to have both. But where you don't have evidence, it's like Bonnie says, you got to innovate. That's critical. But for an innovation to stick, you got to get evidence behind it. So the chief nurses, what was sad to us too, they believed in evidence-based practice, but their own knowledge and skills in evidence-based practice was very low. And then the last thing I want to relate, we haven't talked about learners, our students. And if we don't grow up our students in how to take better self-care, how to build cultures of well-being, I will tell you, the lifestyle behaviors and the health outcomes of our faculty, they're not good. And it's like managers and supervisors. If our faculty don't walk the wellness talk and they don't create cultures of well-being for our students, we're going to have another generation with the same poor health outcomes that we currently have.
Thank you. Thank you very much, Bernadette, for that. I wanted to ask another question as far as how do you all know about these possible solutions? Where do you guys get the information of what solutions are out there? Who is the one that really, who is your person that finds the resources now for mental health? Do you guys talk to one another within the industry, or do you have people within your organization that they have their job to really go and try to find these solutions, or it's just really word of mouth and different presentations like this? I know Jim had mentioned that when you do have certain things you want to share and you want to go out and share anything that you have, but how do you guys really see what solutions are available, what may be working on the East Coast versus the West Coast? Like, how do you guys know what's really out there?
Scour. Scour conferences, utilize your connections, listen to webinars, anything that comes across our desk. But then there's also formal pathways in most organizations, and HR generally owns those. With the input from all the other stakeholders, which is not just nursing, but EVS, housekeeping, everybody else as well, to try to determine. A lot of organizations have a company that they hire that provides the services for mental health, or a set number of free visits that a nurse or any clinician in the organization can utilize. Again, it's about, though, getting them to actually utilize the services, because there's so much stigma around anyone going to anything. So, even simple things like having the flyers on the nursing station desk so that you can just say, Bob, you're looking a little tired today. Are you okay? Did you know that we have this service? You can utilize this service, and not having a big drama around it, right? But just kind of more in the casual daily conversations. So we did find that helped, and helped people to decrease the stigma a little bit. But I think, Bern, that's one of the big issues that we have to address is, again, we can't even get nurses to go to their doctor's appointments, and their mammograms and the different things that we need to do for health prevention. So this is another part of health prevention, right, is mental health and resiliency.
Absolutely, Anita. But I want to call your attention to a major knowledge hub that we have worked on in the National Academy of Medicine's Action Collaborative. If you just Google National Academy of Medicine Action Collaborative on clinician well-being, you will get to a website that has fabulous evidence-based resources, programs, and solutions. I'm on an implementation work group right now that's putting together a compendium of resources and programs. The second good site, and we're doing this with Healthy Nurse, Healthy Nation, we just put together a wonderful resource for mental health for nurses. So those are two websites that I would encourage people definitely check out.
And for us, same as Anita, I think, we have of course, an internal resource pool of people who attend conferences and seek out new programs, belong to collaboratives in professional organizations. We have Caring Science, consortia, which is international. So these are some of the places where we might learn new practices, new micro practices, new opportunities. But we're very fortunate too that we have a Mental Health Scholars Academy, which we formed 2 years ago. And that Mental Health Scholars Academy has obviously a strong commitment to develop the workforce, to reduce stigma, to address inequities, and so forth. And that comes with that academy came the talent and the people who are focused on mental health and well-being. So we have a built-in internal resource that's constantly collaborating with us, joins our activities, helps us design and challenge our thinking sometimes on programs too, about what we should be including that maybe we didn't in the past. And so that's been really great. But one of the things I wanted to mention too, I think has been a real eye-opener for us, and we did an article on it a few years ago, is the importance of partnership between the PhD and DNPs. We went from, out of our 21 hospitals, 0 of our chief nurse executives 6 years ago had a doctorate degree. And today, I'm very happy to say 74% of our CNEs have a doctorate degree or are pursuing one. And that's really important because the focus on practice doctorates and the ability to partner with scientists, nurse scientists and PhDs to be able to really accelerate that bench to bedside, that integration of best practices in the very best ways in education and sharing and collaboration is the model we need to be aiming toward. So building that bench strength internally and really focusing on how to raise the bar from frontline nurse all the way through. And to one of Bern's points around the importance of academic institutions, the academic partnerships, the practice partnerships that we have really focused on, and I know some of the faculty are on here today, working with us to make sure that transitions to practice don't begin when you leave school and enter the hospital. The transition begins on admission to the school. So it's kind of like discharge for a hospital patient begins on admission. The transition to practice begins when the nursing student is beginning their academic pursuits. And so self-care is one of the things our academic partners have built into every one of their programs, and their faculty it's brought great joy and purpose to the faculty. But more importantly, it's teaching these shifts that Bern was mentioning need to happen right on entry into the profession of nursing and be carried through all the way to actual practice.
And Jim, I would build on that to say that we are all in a lifelong learning profession. So it's incumbent upon us to find these opportunities. However, there are some ways to make it easier. I know for myself, I certainly will tolerate as many inputs as I can. So whether it's podcasts or whether it's people sending me literature, journal articles, or things to read, I've curated a reading list. So I'm always happy to share that with anybody. Reach out to me on LinkedIn and I'll share it. But there are some people who I ask them for their reading lists and they will send it to me so that you can see on a regular basis what people are reading, what are the journals, what are the websites that are their go-tos. And there are ways to make that easier for yourself as well, so that when you want to curate, it doesn't take a long time to do it. You can actually build along your toolbar all the little buttons that take you directly to the websites for the journals or the webs that you want to go to on a regular basis. So all you have to do is click instead of type or search. So there are ways to make it easier for yourself, but information is flying around so quickly right now. It really is important just to continually be out there and see what's going on. And as Anita said earlier, I mean, basically we need to be sponges and figure out how we can process information. Even if you can take a little pearl or nugget from everything you hear or read, that's huge. And then just sort of pass it along.
Thank you for the nugget comment. It goes right into my segue of what's that one nugget? Because we're going to be getting ready to wrap up a little bit here. So I want to ask this last question to our panelists. So let's start with you, Bonnie. What would you say is that one nugget you want to hand off to your audience about all your hard work and the amazing insights?
Oh, start with culture. Just gratitude and culture. If you can start there, everything else can build upon it.
Any of my other panelists? What's the one nugget you'd want to hand off to your audience about all the hard work and amazing insights? Jim, would you like to take it up next?
I think for me, it's stay curious and always, seek new ways of doing things. I think we get so fixed in our culture around fixing things and repairing what's not working. When, I think more and more of my work, I want to blow things up and just start over, because I think we mentioned at the onstart here, things are not working well. And we're finding a lot of things that need to not just change, but they need to either stop being done, or they need to be done totally different, or we just need to find something new to replace it entirely. So I think the curiosity, and that brings joy and purpose to me, is if I stay curious and I stay connected. So I would go with curious and connected.
Love
I was
that.
going to say, find the love and embrace it and share the love. And you have to have love and joy in your life. And the more you find it in yourself, the more you'll have it for others to give. So stay focused on how you're tuning yourself and stay accountable to yourself so that you have lots to give to others. It really works.
And I would add, self-care is not selfish, because we cannot continue to pour from an empty cup.
Mhm. Beautiful.
I love that. And I wanted to go back to the partnership and solutions that you guys have. It's a lot about collaboration. And as my focus is on mental health and solutions and trying to find what's really out there. And there is no one size fits all. So it goes back to that multifactorial approach of trying to see what are these solutions. And I like the fact that even though we can find one solution, but we know there are different levels that we need, especially when it goes to mental health. We have those that may not need such intense solutions, but now we're dealing with a whole pandemic that's really bringing out the ugly side of mental health for nurses. So now we need something a little bit more one-on-one coaching, more one-on-one psychiatric evaluations. And so it's really trying to collaborate with the system that's really out there and trying to get these solutions into one place. And like Bonnie mentioned earlier, it's not just having these solutions there, but making it easy and accessible. Because yes, right now we know that there's a lot of things out there, but how do we really get to it? And I think right now we're working on trying to get those solutions really accessible to these nurses. So I wanted to say thank you to everyone for all of your comments. And if there's any last minute things that you'd like to add, or any other insights, or something that maybe we just didn't talk about that you'd like to add, by all means, you have the floor.
I wanted to mention mental health first aid, and I'm not sure if people are familiar with that program, but it's something we have scientists in our organization who are very passionate about teaching it, offering programs now virtually across the region. And I think it's one of those things that really, when you talk about reducing stigma, it's about increasing awareness and helping educate people. And I think that mental health first aid is one of those programs that's a really great first start. I would say that's the cure-all for where we need to be, but it's certainly a wonderful first step for an organization to look at.
We also used, sorry, my computer's a little locked up, so I can't share the link, but to start discussions in our organization post third wave of COVID, or in between the waves, we used Rose Sherman's trauma-informed nurse leadership, and it asked 9 questions, and it was just a great way to start the conversation around for the letting go ceremonies and what people are doing and how what they were challenged with and how they're going to move forward. So sometimes it's good to have that little tickle of information to start the conversation. And Bern, I can't wait to look up all the compendium of work that you've done. I think that's awesome to have that website where you can go to that has different levels, different things, and just search around there and figure out what appeals to you. And every single person, has a voice, and be passionate about what you want to take away from today, and find a tool, find something to start the dialogue with your managers, with each other, but start having the dialogues about resilience and self-care and what we're going to do coming out of this COVID pandemic that we have experienced. So find yourself.
Thank you. Thank you. So just to summarize a little bit of some of the things that we discussed today, I think I got a lot about evidence-based practices. I've been a sole cheerleader for evidence-based practice throughout my nursing career, because if we're not following evidence-based, then what are we really doing? We're just pulling things out of our hats to let's see if it works. No, evidence-based is what really works. And it goes back to the quality and safety that your administrators were trying to achieve, right? They're trying to get that quality and safety for their patients, but if we don't have that evidence base to back it up, and we're not really hitting our goals. So I definitely take back to that evidence-based practices. And another thing that really resounded a lot was culture. It's all about the culture of your organization, and not just the culture, but we want the leadership that also backs that culture. And what kind of culture has to be something that also supports wellness, right? So that's a big one that I heard a lot about. And I really like that daily dose of gratitude, because it goes back to that evidence-based practice. When you have that gratitude, there's a huge wave of different feelings that we get. So definitely getting back to that daily dose of gratitude. And something that I definitely agree wholeheartedly, and I mentioned it earlier, is we definitely need to come up with this multi-component approach of these solutions, and how can we really collaborate. And I thank all of you guys for joining us, because this in itself is a collaboration, getting the feedback from the nurses, our audience that's here. We're all reading everything that you guys are saying, and we're taking into account of what is being said. And we really want to put into practice what this discussion is about, and trying to really find the solutions and get it implemented. And Anna of California is doing its best to not just talk about it, but be about it. So thank you very much for joining us. Dan, I'll let you close up.
Yeah, I just want to say thank you. And, when we asked the panelists to join us, everyone responded within, I think, an hour and said, yes, we are more than happy to jump on this. And you can tell they're passionate and experts in this field. And I speak for all of them, including ourselves and ANA California, to say, if you need resources or want to learn more, we are all 100% willing to support you in your journey. This is a national pandemic of nurses' mental health, and we're seeing it burn out. There's not enough nurses, and this is our new normal. So we have to move forward with pathways to support the people we have, and think differently about the workforce of the future, and support them in ways that they may not have been supported in the future. So I want to thank everyone. Carolyn did an amazing job as our moderator. So virtual round of applause for the panelists and for Carolyn in doing such an awesome job. ANA California will send out an email with follow-up with all the links that we shared in the chat and resources that we talked about today. So you'll have those. And again, please reach out to us. We're here to support you. And thank you so much. Marketa, did you want to say anything to close out?
No, thank you. You did it perfectly. Thank you, everybody. We so appreciate your time and your expertise. Thank you to our panelists. This has been absolutely amazing. Thank you.
So have a great Tuesday. I think it's Tuesday still. Have a great Tuesday, and take care of your mental health. Thanks, everyone.
Thank you, everyone.
Bye, everyone. Thanks.
Care.